Okay. We'll start getting a lot of people joining in now. I hope everybody's internet holds out. I think more and more people are starting these Zooms. I think we were a little bit ahead of the curve on getting these going over the last week.
You've always been such a trendsetter, Dr. Marshall.
What's that?
I said, you've always been such a trendsetter.
Leading people down one either a good direction or a bad sometimes, I think. So this has been definitely good at distracting me from all the coronavirus stuff this week.
Yeah, for sure.
So I think the India and Pakistan people will be joining us at like 11 o'clock or midnight their time. So
wow.
It's dedication.
It's commitment.
they were quite not too excited about the later lecture today at 1:45. So we'll have to figure out how to, if they want to watch it later, we'll figure out how to get if anybody knows how to set up something.
You're going to try to upload these though, right? Somewhere to.
Yeah, I have them right now. I have them in a Google Drive.
Mm-hmm.
But I don't know how to make that so people can just get a link to the different ones and that kind of stuff. So I'll probably need a millennial to help me with that. Hi, Jackie. Everybody's bringing their cat today. I love it.
They're becoming our coworkers.
Yeah, that's true.
They're really our supervisors.
That's true.
Okay, well, I'm going to start sharing my screen and start talking now that it's 11, and I'm okay. Here we go again with cat class. I'm really excited. I'm especially excited because I don't have to do the content today, that we have two great people to do that for us. Does anybody know Dave Mahoney? He went to LSU, graduated a couple years ago. He's a Therio resident, I think, in North Carolina now. But he got stuck at my clinic for a few weeks. He was planning on another clinic in the area, and that one fell through a couple of years ago. And so one of his mentors sent him over to me, and he was hard and fast and determined to make Fridays for everybody around the world be Hawaiian Shirt Day. And so I'm trying to represent for that. And if you ever meet him, he's probably trying to get it to every day now, even though he's not from Hawaii. So that's the reason for the Hawaiian shirt. And so we've got an updated schedule. Excited today about ER. And don't know exactly what I'm going to talk about yet. I'll probably put a poll out on Instagram about topics for next Wednesday. I have secured Kristen Woolner for Thursday. And she, I don't know exactly what she's going to talk about, but it's going to be good. She's a really, really good communicator, really, really good speaker. I've gone to a lot of lectures at a lot of conferences, and one that held me riveted the best and that I really, really got a lot out of was a talk that she did at AVMA last summer. And it'll definitely be an uplifting one, whatever she decides to talk about, and we'll be happy we got to hear her. And then Ashley on Friday with at DermVet, and we'll probably be at a different Zoom account number next week. So follow that, look at my Instagram bio, and as if we change it over the weekend, it'll be posted there for Monday. Okay, on Monday, we have Dr. Lo Curtis, a neurologist that used to be up here in the Seattle area when she went to school and did internship, and now I think her residency was up here too. Well, we'll find out on Monday. But now she's in Austin, Texas, practicing neurology. And she also has a podcast called Thrive Podcast. And her recent one was with another friend that's going to be signed up to go camping with us this summer at our Vets Outdoors. One of her recent ones was with Jackie Horner, which is really, really good. So I think she'll probably tell you more about that on Monday. And today we have Dr. Mel and Dr. Paula talking about ER. I gave a little shout out and introduction to them yesterday. Paula is, I think we met on Instagram probably a year and a half ago when I saw pictures of hers from the Olympic Peninsula where we are and where we go camping. And I think we might have been there at the exact same weekend, but we didn't meet each other there then. And we still haven't met each other, just on Instagram. But I'm excited that she's willing to help out today because she will be a better moderator with questions than I am on ER stuff. And Mel and I have been good friends for a little over a year now. And we got to know each other best at VLC, Veterinary Leadership Conference. I don't know if anybody's been to that in Chicago. It's always the first or second weekend in Chicago in January, which is just an awesome time to be in Chicago. She came as our sort of rising leader from Washington State. And both of us were going through some pretty shitty stuff back then in our personal lives that were really affecting us, and we got to share those and bond over those. And I would say that over the last year, she has truly become a mentor to me in a lot of aspects, and I just really respect her. And she's, I keep thinking she was like a 2002 grad, but it was 2016. Is that right?
Yeah, that's right. But we both rose like phoenixes. Come on, you've been a mentor to me too.
But she's way more mature than I am, so that's why she can be a mentor to me. And one last picture before I go. This is just a shout out to WSU seniors that they weren't expecting to graduate this week. That is not a picture from this week, obviously, but that is one from a few years ago that I took. That's Dr. Rongren in the middle there, that she could not join us today because she's actually working in a clinic. But congrats to all the WSU new DVMs that got to put DVM after their name this week, even though it was not expected. Okay, I'm going to stop sharing now, Mel, and let you take it from here.
Okie dokie.
And start your show.
All right. Well, I thought I'd start with just introducing myself a little bit and then give Paula the same opportunity to do so. Like Dr. Marshall said, I'm a 2016 grad from WSU. I worked initially for Banfield for a year, and then for 3 years for family-owned practice in Spokane, Washington. And then for the last almost 8 to 9 months, I've been running my own relief business. And I've been doing a significant amount more ER work with that, and something I never really thought that I would necessarily be doing, but I absolutely love it. And it's been a really fun new challenge. I totally geek out on the complexity of the medicine and having to stay on your toes and the activity. So a little slide about me. I'm a huge avid hiker in my off time. I'm hoping to do some more long distance backpacking this year. I'm a hot yoga convert and addict in the last year. I love connecting and mentoring students and being with other veterinarians. I live close to WSU, so I do go down to the campus and do talks down there, and that's the current VBMA leadership at WSU in that picture. And then I did recently get the opportunity to do a TED Talk. So I am that Dr. Bowden, if anyone was wondering. And so that's been really awesome as well. There's been a lot of great connections coming out of that. Different people that have just emailed me personally their stories or looking for mentorship. So that's been one of the upsides to the Corona quarantine for me, has been that I have time to really connect with those people on a meaningful level, which I wouldn't have time if I was working full time. So I will put in a plug for the summer camping trip. Go to my Instagram account or Jackie's or Dr. Marshall's, and you'll be able to find more information there. That's the picture on the bottom right, was from that last year. It's a super fun time, great people to get to connect with, and just fun to be outside. So Paula, I'll give you a few moments to kind of give your background.
Sure. Thank you so much. Hi guys, I'm Dr. Paula Simons. I am a new graduate. I graduated in 2019 from Ontario Veterinary College. I'm actually from Philadelphia, Pennsylvania, so an American, so did schooling internationally. So if anybody has questions afterwards about that, I'd be happy to talk about it. So initially, before going to vet school, I worked predominantly in general practice and never really imagined myself going into emergency medicine. Throughout vet school, I was also super adamant against doing an internship because I felt like it wasn't the financially feasible decision to make. But lo and behold, as I kind of started figuring out the different routes and where I wanted to be, I realized that general practice wasn't for me, at least not right now, and decided to do a small animal rotating internship. So I'm currently doing that at a very busy, small, well, not small, large private practice in Mississauga, Ontario, which is just outside of Toronto. So we have a pretty large, diverse caseload. So yeah, right now I do a lot of emergency work and really fell in love with it, but more so fell in love with in the intensive care unit or critical care. So now I will be doing a residency, an ECC residency outside of Boston next year. So like I said, if anybody has any questions regarding those types of things, I'm more than happy to talk about it and give you my perspective as well. But I'm pretty passionate about emergency medicine in a bunch of different scopes. And I think cats are truly kind of one of those mysterious animals that when things go wrong, they're usually pretty bad. So I'm really interested in hearing what Dr. Melanie has to say and contributing in any way that I can.
And Paula, just sorry to butt in here, but do you want to tell everybody about your Zoom on Sunday?
Oh, sure. So this Sunday, I always get a lot of questions about internships. I have gone to OVC, Ontario Veterinary College, at least once or twice to do internship talks with our intern director. And so I always get a lot of questions from students regarding, the process of applying to internships, why I chose to do an internship, doing an internship internationally. So I think that there's a lot of kind of knowledge that's not well dispersed unless you've had some point of contact to chat with about it. So on Sunday, myself and then a veterinary neurologist who trains a lot of interns will be having a discussion, just an internship Q&A similar to this, where it's just an open forum discussion. I have a bunch of really great questions that I've already compiled that I'll be addressing, but if anybody wants to join, that'd be fantastic. Or if you have any questions and can't come, then just send them to me directly.
That's your time. You said 3?
Yeah, it's 4 p.m. Eastern.
And it'll be on this this Zoom account as well.
Yeah.
So cool. 4 o'clock Eastern. Okay. Sorry, Mel.
Awesome.
Go ahead.
No problem. So I thought I would also start by sharing a couple of my favorite resources to have in the clinic. So my favorite ER book is this one, Emergency Procedures. It's by, I'm going to butcher this name, but Signe Plunkett, Plunkett. This is, as a traveling vet, I need a smaller, more compact book I can take with me, and this is my Bible. I also really like the Animal Veterinary Nerd book by Sophia Yin. And then I do encourage all of you, as you start practicing, to create your own nerd book. So this is mine, Advanced Potion Making, because I'm a Potterhead. But it basically just contains cheat sheets, notes, things that I have found useful as I'm working up my cases, just so that I have easy, quick reference. And I find that also helps me kind of continue to do medical case logs and go back through my records and what could I have improved or what could I have done differently, which I think as a newer veterinarian is always a great skill to start. So today we're going to talk about what happens when emergencies walk in. And I really wanted to talk about this with this group in particular because for me, my personal like nightmare that literally would keep me up at night when I first graduated was the concept of being the only vet in the practice when something life-threatening came into the clinic and what to do. And my own imposter syndrome shows up as me thinking I'm unqualified and that like we should get a professional to do this. That's literally what my brain says. And then I'm like, oh crap, I'm the professional. So as a newer veterinarian, that was something emotionally that was hard for me. So this is geared towards basic stabilization, helping you guys realize that emergency is not as scary as it sounds. And so for me personally, these are my 3 mantras. You got this. This pet is lucky to see you because it could have been DOA, right? And it's lucky that you're there to help it. And it's already trying to die, so you might as well try to do something to help this pet. So whatever helps you kind of logic your way through it, but these are some of my sayings to help pep myself up. Today we're going to try to get through as much of this as we can, but I recognize it's an ambitious list, so we'll see where we get. But I wanted to start with the 3 emergencies that you don't have time to look up in a book. So there are 3 things that are life-threatening walking into your clinic that you really won't have time to research or could die while you're researching. So we'll go through those and what to do to stabilize them. We'll also kind of talk about cats love to go into decompensated shock, like they like to come looking like they have one paw in the grave already, and kind of how to do some basic stabilization, basic information that you want to get on those types of pets, and kind of how to start working those up. We're going to go through running a CPR code and having CPR conversations with clients and the recovery initiative. And then I picked a couple of basic cat emergencies that you're probably more likely to see, like blocked cats, polytraumas, hypothermic cat and kittens. I do see those a lot because I live in the north. I would like to talk a little bit about ATEs if we can get there, because the classic saddle thrombus is not always the way you see those. And then we had talked a little bit earlier in the week on hepatic lipidosis and refeeding. Paula and I had started nerding out on nutrition. And so I figured we should talk about that a little bit, because I actually wasn't taught about refeeding syndrome in school. So I thought that would be good to put here too. Okay, and if Paula, if you could keep an eye on questions, because I can't see that on my screen, and just interrupt if something comes up. Okay. So the first emergency is seizures. So cats, thankfully, don't seize often, but if an animal comes in status into your clinic, that is a life-threatening situation that could go south pretty quickly. The main, sorry, it should say hyperthermia, sorry, hypoglycemia, are the main 2 reasons why a pet would die from an active seizure. So the most important thing to do is to stop the seizure in its tracks. And then once the pet's a little bit more stable, kind of thinking through why is it seizing in the first place and trying to delve deeper. Valium and midazolam, either one works fine as your primary medication for stopping seizures. They both can be given intranasally or rectally. There have been a bunch of side-by-side studies to look at efficacy, and it actually looks like both are pretty similar. Maybe midazolam's better in some of the studies, but it doesn't really matter. For ease of dosing, generally speaking, 2 milligrams IV for the average cat, because cats generally are 10 to 15 pounds, which ends up being about like 0.3 to 0.4 mils of a 5 mg per ml solution, which is kind of what's generally available. So that's kind of my emergency dose I keep in my brain for kitty cats that come in seizing. Lots of emergency stuff needs to be done as much as possible simultaneously. So knowing who your strong LVTs are in your practice. So as you're running to the drug cabinet to pull out that midazolam, having them place an IV catheter. And then I usually try to get a blood glucose on these guys right away just to see where it is. The blood glucose reading can be a little bit chicken or the egg. Sometimes a prolonged seizure in and of itself can cause mild hypoglycemia, but that's usually the first thing that I would check from a blood work perspective, and then correct if needed. And then once the pet's a little bit more stable, thinking through diagnosing underlying causes of why they started to seize in the first place. So make sure you're getting a great physical exam done. Other vitals to think about would be, just kind of your general, where's the temperature at? Do we need to start cooling? Fluids can often help with that as well, blood pressure, that kind of stuff. And then in cats, the main rule outs for seizures are kind of what I've listed at the bottom, but that's certainly not entirely, inclusive of all things, but kind of the most common things that we think about. Part of the reason why I do get blood pressure on these kitty cats isn't because I think it's too low, but I'm worried about it being too high. So if they threw like a clot or a polycythemia, hypertension, things like that can be a reason why cats seize. Do you have any additions, Paula, to that?
I think the only thing that I don't see is neoplasia. I would definitely see that, that 10 to 15-year-old cat, new epileptic. My main differential is usually cancer. Not necessarily if they're in status, but if they're having first or second time seizure at that age, then my main concern would be cancer.
Yep, definitely fair. And that pretty much can be thrown on all differentialists and cats that are coming in that are really sick. Okay, so that's one ticked off your list. There are only two more that you need to learn about that you that you don't have time to look up. So active blood loss is the second one. The tricky thing in cats is when you're thinking active blood loss in kitty cats, think about fleas. Most of the cats that I've seen come in that are coming in with this primary issue are usually either a polytrauma, so they were like hit by a car, or attacked by a dog, something like that, or they have a super high flea burden and potentially also secondary mycoplasma. So if you can see it, stop it, place a tourniquet or apply pressure to the wound if you see an active reason why they're bleeding. Tourniquets can be left on for 30 to 60 minutes without permanent damage. The one caveat I would say to that is if you don't place it correctly on a front limb, you can cause radial nerve damage in cats. So trying to stay away from the elbow. Some papers say though that you can have it on for up to 2 hours before an amputation would be needed. But again, at this point, I'm thinking about saving the life of the pet over saving the limb of the pet. So if it's needed, don't be worried about placing something like a tourniquet. Kill fleas fast, so give that cat some Centrigard or whatever to you have on hand to try to get rid of the fleas. Sometimes I will actually, if they're not hypothermic, actually bathe the cat potentially as well to try to remove physical fleas. And if you do have a suspicion for underlying toxicity or like that they got into a rodenticide or something, you can give a single dose of K1, but remembering that although that's helpful, that's not going to necessarily change the situation like right now. Those cats, if they are actively bleeding from a rodenticide exposure, are probably going to need blood product more so than just supportive care. So again, simultaneously having your LVT place a catheter and considering whether or not you need blood product. So not every hospital has access to blood product. And in those cases, if it is an acute trauma or an internal bleed, you can auto-transfuse the animal. It's not a great option for pets with neoplasia or infections. That's something that we talk about more usually with dogs with like hemoabdomens. If there's a concern for like a splenic tumor or something like that, you don't want to be transfusing blood that's full of possible cancer cells and metastasis. And certainly if they're infected, if there's a potential for an infection in the area that they're bleeding, like they had a ruptured uterus or PIO or something, you don't want to be spreading that and giving them sepsis. So that's one consideration. If you don't have blood product, and this was a situation in general practice that I was in, I didn't have blood product in my hospital. And so for those kiddos, we usually gave some shock boluses of fluids because in acute blood loss, they're not compensating for that anemia. And then we would transfer to the nearest emergency hospital that had blood. The other thing to remember is part of the reason why they need blood is because they can't, they're not circulating their oxygen right well. So a lot of these kiddos, I will put in an oxygen cage or give flow by O2 to make sure that the red blood cells they do have are fully saturated. And then blood typing and matching. So, and maybe Paula, if you've done more blood transfusions than I have, you can give some advice on this. But my understanding is in cats, yes, you do want to try to blood type and match before you give your first transfusion. In dogs, you can get away with one, not knowing, but I feel like in cats that's a little bit riskier. What are your thoughts on that, Paula?
Yeah, so dogs are typically DEA positive or negative. So
Mm-hmm.
I believe, if I'm correct, the general understanding is that you can give negative blood,
Mm-hmm.
kind of like us with rhesus factor. Cats are typically type A or type B, with predominant, cats are predominantly like domestic short hairs and whatnot are type A, but there's still a small percentage subpopulation that will also be type B, but then we see a lot of purebreds that are type B. So there's more of a risk with transfusion reaction with cats than with dogs, because dogs, you somewhat have a universal donor. Cats, not so much. So you definitely need to type them beforehand.
Yeah. Yeah. And yeah, I agree with that. So, and then, once again, once they're a little bit more stable, then we start looking for underlying causes. So trying to do a workup for additional trauma, thinking about things like, do they have, mycoplasma? Do they need some doxycycline? Is it an IMHA? Things like that. So supportive, additional treatment plan, supportive care really depends on why they are acutely anemic and decompensating. But your initial stabilization, especially in a daytime practice where, maybe you don't have blood product, is really to think about stopping the bleeding if you can, getting those fleas off, and then trying to stabilize the pet from a shock perspective, and then think about if they're really so bad that they need blood product, how do we get them there?
Gary had a quick question about
Sure.
iron supplementation. Do you typically supplement iron in an ER setting? Or is that something that, if needed, the GP will do?
I will say I haven't. I mean, most are not iron deficient anemias. So usually whole blood product is what they need more so than, just an iron supplementation. Is that your experience as well, Paul?
Yeah, I mean, I haven't seen many iron. I know there are primary iron
Mm.
deficiency anemias. I haven't seen many, and the anemias that I think of, like IMHAs or whatnot, I would assume that with the hemolysis they would be recycling that iron.
Mhm.
I don't know how that applies for we don't really have flea anemias as often in Canada. It's too
Mhm.
cold, but I don't know, would it be beneficial in those where the blood is actually being leached from the body so they can't recycle iron?
I mean, it's a good thought. I mean, honestly, I haven't really looked into it because usually those cats either respond pretty quickly to doxycycline and some prednisone to get rid of the parasitic component,
Yeah.
and regenerate pretty well, or they need a full transfusion because they're so decompensated. So, like the last one that I saw that actually passed away came in at 5% PCV, and when they're that bad, iron's not going to help you.
Exactly.
Um,
Sarah,
so
Sarah
yes,
had a question, and I feel like this could be its own lecture in and of itself.
sure.
But what type of fluids do you typically reach for shock and stabilization?
Very good. I think for it can be its own entire lecture, but I think from a simplified perspective, I usually think of one of two groups of bags in my daily practice. So I either have a balanced solution like an LRS or a normal sol or something like that, or I have sodium chloride. And I grab my sodium chloride for my cats that I think are really sick and probably have some sort of derangements happening. So I usually grab that for, my blocked cat, my ADR hasn't been eating for several days, laterally recumbent cat, like things that are super, super sick. I usually go with sodium chloride first because you're not going to make anything significantly worse with that solution. With more stable cats, and for something like this where the cat was totally healthy prior to having blood loss, right? So that cat maybe an hour, 2 hours ago was a total healthy, normal, like electrolyte balanced cat. Then those ones I typically grab like an LRS or a Normosul for, and do my boluses that way. I will say with really bad anemias, you do have to play that line a little bit between supporting blood pressure and dilution of the blood. So I often don't give my full shock bolus that I normally would do. I kind of am monitoring my blood pressures in response to the boluses that I'm giving, but I usually start with like a eighth to a quarter shock bolus, see where that gets me, and then kind of go from there. So, because you do have to worry a little bit about further hemodiluting the pet and making the symptoms of the anemia worse. Mm-hmm. Okay, are we ready for the next one, or do we have another question?
So there was a question about using hypertonic solutions.
Sure. So my experience with hypertonic solutions, so like a hypertonic crystalloid or something like that, you could potentially use that to increase your blood pressure without having to give as much fluid. I do worry a little bit about acute kidney injury because if they are hypotensive and in shock, they are not perfusing their kidneys very well. So I typically use my hypertonic salines and things like that more to correct like anesthetic induced hypotension, situations like that where I have a better chance of making sure those kidneys are okay. I tend to reach more for like vasopressors and things like that if I really need to, as opposed to like a hypertonic saline. So yeah, you agree with that, Paul?
Yeah, I very rarely,
Yeah.
I mean,
Mm-hmm.
obviously I don't have as much experience as you do, but I very rarely use hypertonics. I think and honestly, it's very case dependent, right? So a lot of these cats that come in that are ADR not doing well are probably pretty systemically dehydrated. So by giving them hypertonics, you're just pulling interstitial fluid that's probably not there, and you're really compromising their kidneys. So I would say, start with, a quarter shock bolus, see how they're doing, reevaluate blood pressure, and if they're not responding to fluid therapy, then, check their other parameters, and then from there, do you need to start a pressor? Because, to a certain degree, a pressor is probably a bit safer than, bolusing hypertonic.
Yeah. Okay. All right. So our third emergency is respiratory distress. And I think this is likely to be the most common one you will see in cats walking through your door, the cat open mouth breathing. And it can be acute onset, like at home, they were like kind of off and weird, but now they showed up at your clinic and they're like dying because the stress of the ride, like made them decompensate. So, so respiratory distress is definitely something that you would more commonly see in a cat coming in as an emergency situation. The biggest thing to remember in these kiddos is that your x-ray is not the most important thing immediately. You want to get it eventually, but you could kill it trying to take an x-ray before we do some other stuff. So first, provide oxygen support, whether that's flow by. If you have an oxygen cage, great. Tracheostomy tubes are generally not needed in cats because usually they do not have an upper airway obstructive issue like a bulldog would, or something like that. But I do always do a quick oral exam on these kiddos just to make sure that they're not choking on something, because I've definitely seen cats that eat like milk bottle tops and weird stuff, and I've definitely had cats that had that issue. So make sure that we're oxygenating them. The other thing that I get for them immediately is something to reduce stress and anxiety. So as a person with asthma, I personally experienced this, but part of the chain of respiratory distress is that you can't breathe, so you try to breathe harder. This induces panic. It makes your airways become more inflamed because you're breathing harder, and it creates this horrible cycle, and like it's just awful. So we also wanted them to be breathing better, breathing more deeply, and more effectively with each breath. So I usually give them Torb. You're pretty much guaranteed to never kill anything with Torb. So if you want to give, and Torb is not great always for pain as a pain choice. If I had a pet that was more painful, I would pick a different opioid, but Torb is great for the sedation component and anti-anxiety component. And then again, as you're stabilizing this pet, and usually I put them in the oxygen cage with Torb and give them a few minutes in there to fully oxygenate before I take them out again and let that Torb sit. But the next time I take them out, I usually try to put in a catheter first, put them back in the cage because we want IV access in case they do decompensate on us and we need to do CPR. And then once they're pink again and they've had a few moments to rest, and we already have the x-ray set up, we're already gowned, we're ready to go, I take them out and I just try to do a kidiogram in whatever's the least stressful position for them. So usually that's trying to snap a quick lateral. And then, you know, if they're stable enough, usually I try to do a DV instead of a VD. I also find, I'm sorry, do we have a question?
Yep, just a quick
Sure,
question about
go for
using benzos instead of like if you would ever use a benzodiazepine instead of an opioid, or I don't know if it's instead of or in conjunction.
Sure. So opioids are considered the safest thing to give a pet, especially if you're concerned about heart disease. So even though it's not an anxiolytic, it does provide that light sedative quality for them. And a pet that has heart disease won't have an issue with it or need a dose change. You could give like a midazolam Torb combo. I generally don't just give straight midazolam because, or Valium, because I find that some pets become high and like they get more kind of dysphoric, and that's not something I want. So generally speaking, from a clinical perspective, giving something like Torb gives me that kind of like, oh, the world is at peace cat, right? Like we just want a meditative, like I'm going to purr a lot, chill kitty cat. And Torb usually gets you there. So that's been my drug of choice. And if I do choose to give something like a benzo, I give it with an opioid to prevent the dysphoria. I do find in these cases, your physical exam can get you a really long way. So generally speaking, asthma, heart failure, trauma sound different. So asthma, generally speaking, you either have decreased lung sounds because they're so bad that they're collapsed, or you hear an end inspiratory wheeze on the end. That's a little whoop at the end of your auscultation. Heart failure, you can't always hear a murmur on cats, but often if they are having cardiogenic edema, you will hear some crackles in those lungs. And then with trauma, usually the most common reason why they'd be in respiratory distress because of trauma is because of a pneumothorax. And then you can't hear lung sounds in certain areas of the lungs. So a good physical exam can sometimes get you some information if you were in a situation where your pet was so unstable that you wanted to try to give a medication as part of your stabilization process. So, and generally speaking, a single dose of Lasix or a low dose of dexamethasone or something like that, even if the cat had heart failure and you gave a little bit of Dex, or the cat didn't have heart failure and you gave a little bit of Lasix, generally speaking, not going to totally ruin this animal. So if they were that bad and you have a gut instinct towards, I think this is heart failure because the cat's previously had an issue, or the cat's had asthma for years and now is coming in blue and you want to give some pred, generally speaking, I go ahead and do it if I have enough information from my physical exam and history of the animal that it seems appropriate, even before I've taken the x-ray. And then, so then your last priority for these kiddos is to get images and a diagnosis of what's really going on. And the picture on here was a case that I had that came in was heart failure, and it had pleural effusion. So that's what the arrows are pointing out, is those nice little lung lobes floating, floating in the chest cavity. So those are your 3 basic emergencies that you don't have time to look up and would need to kind of take action right away. So seizures, blood loss, respiratory distress. Everything else that walks into your clinic, generally speaking, you will have time to look something up in a book and to kind of figure out what's going on. So the last one that I wanted to talk about in general for kind of generalized ER cases and triage is kind of, what do we do with that ADR kitty cat that's just like not really actively trying to die and like, run into the grave, but it looks like death warmed over. And they do come in like, just kind of laying on their sides. They're not really that responsive. Maybe they're hypothermic, like they look kind of shocky. But on physical exam, you can't really pinpoint anything specifically wrong. Like it doesn't have a big bladder, doesn't look like anything's broken. Maybe it's an indoor only cat. Like, and you're like, what happened? Like, so for these kiddos, exam TPR is really important. And then often I just start general supportive care while we're trying to get some diagnostics done. So I usually start them on a balanced solution for fluids. I do start actively warming these kitty cats because they're often hypothermic. And then I do usually try to address nutrition and appetite, especially if their blood glucose is kind of on the lower end. Whether that's sometimes giving them a little like dextrose on their gums, give some Serenia, that kind of thing. Once they're a little bit warmer, often they're more mobile, and we'll try to eat. But your basic database of blood work, CBC, chem, lights, UA, FELV, FIV testing. And then, if your blood work's not showing anything, then thinking about things like trauma or, is it a foreign body or, what's going on. I would say that often in these cases, because sometimes clients are coming in being like, well, he's declined over 4 to 7 days and like, we don't know, he's just older and, they're kind of like, maybe it's time. If we're going to work up the cat, then I usually try to work them up based off of what's going to give us the most information about treatment moving forward. So I often will offer FELV, FIV testing as my first diagnostic, only because in a lot of these situations, if it's like a middle-aged older cat and the FELV, FIV testing is positive, a lot of owners might choose to stop there. So from a diagnostic standpoint, sometimes it is what's most efficacious or what's most needed to actually know medically what's going on with this pet and how we fix it. I think other times it's also like, how severe is this? And are we making a decision on an ER clinic basis of do we treat or euthanize? And in an actual ER setting, that is often the first hurdle, is that they come in with animals that are really, really sick and don't look good. And they're looking to us for prognosis. Like, is this actually fixable or not? And so sometimes our first diagnostics on cats like this, outside of basic kind of stabilization procedures, is to try to get some information around, how severe is the illness and do we think this is something reversible? Do you have thoughts on that, Paula, in terms of how you kind of address these kitties?
I mean, I think it depends on the perspective of the clinic that you're in.
Yeah.
So I practice in a bit of an area that's in Ivory Tower. We have a demographic of clients that typically will go for things. I very rarely have to, I do euthanize because of finances, but it's not often the case. So in my clinic, there's like maybe this ongoing joke that everybody gets blood work, everybody gets an abdominal ultrasound. A lot of times depending on what's going on, and we have portable ultrasound, so we can do a TFAST and say, all right, does it look like this is primary pulmonary or cardiac disease, or are we screening for abdominal disease? So that's kind of, for me, a quick and easy assessment that will help me target which way I'm going. And I know most GPs don't have the luxury of that, so it's probably easier just to do an X-ray. So a lot of my patients will end up getting chest X-rays, abdominal ultrasound, especially for that ADR cat that comes in with very vague clinical signs. A lot of times I prepare owners that for the most part we will likely need to do multiple screening diagnostics. And
yeah, and I agree with that. I think for me with we always joked in my ER in Spokane, because we do have some clients like that, and then we do have a lot of clients that are like, well, I'd like to fix it, but you have $500. So in those cases, we're always like, yeah, we want X-rays and blood work, and they're both valuable in most cases. I think with cats, I lean a little bit towards blood work because often they haven't been eating for several days, and I'm really curious about hepatic lipidosis, apart from whatever else made them sick. But yeah, it is very kind of dependent on the case. So I definitely wanted to get to running CPR. This is a picture of my team in the ER that I work in most often. And this is them actually running a code. So the girl up on the counter in the back in the blue pants, black shirt is actually doing compressions, while the girl to her left that's facing that pet is giving oxygen support and breaths. These 3 techs in the table in front of us are drawing up emergency drug doses. The girl in the Minnie Mouse shirt is my tech that doesn't have as much technical experience. So she is keeping records for us of what we're doing and the timing of everything. The LVT in the center, the blue shirt, is our senior LVT. So she has access to our drug box and she's pulling up all of our resuscitation meds. And actually the 2 on the far left are working up a totally different case. But this is what our ER looks like at these moments. And I think the important thing to remember is, as the doctor, you are far more important to be the ringmaster than you are to actually do the CPR itself. So up until you are the doctor in your life, a lot of times you are the person doing chest compressions, placing an IV catheter, maybe intubating. Those are the things that you typically do in school when a CPR happens. As the doctor in the clinic, often your job is to provide direction to your team, and that is more important in that moment than necessarily you doing those things. So in terms of current standards for CPR, I think the Recover Initiative right now is pretty much everyone's guideline for CPR kind of standard of care. Has everybody been introduced to this? Is this completely foreign to anyone? The CPR algorithm? Anyone? So you can get these, so this, and then on the next slide, there's a CPR drug chart. You can get both of these online through the Recover Initiative website. You can get personal use ones, I think, either free or for a couple dollars. They have larger posters and stuff for clinics that they sell. But again, so for myself, the way that I typically run a code, with minimal people, I'm usually drawing up the first drug dosages because you might be the only person that has access to the lockbox. So usually that's where I head when someone yells code in our clinic. The LVT is trying to place a catheter and intubate that animal as fast as possible at the same time that an assistant is usually starting chest compressions. And then whoever the next person is available, assistant kennel reception, starts my log of documentation of when did code happen, what drugs are we given, that kind of thing. So we have the timing. And then once the LVT is available from catheter and intubation, and we have someone that's on the bag to give breaths, then often I will give my LVT instructions in terms of, if 1 minute goes by, this is the next drug you're giving. I give them that list of when to give, what to give, how much to give. And then I try to go talk to the client. And that's just my personal preference, because I found that sending other people to talk to my client has often been ineffective. And the client doesn't really know what's going on and has a harder time making a decision because really they're looking for the doctor's opinion about how recoverable this is. In an ER setting, I will say that the vast majority of the reasons why pets are coding is because of end stage problem, right? So if you have like a heart failure patient that codes, it's because they've literally drowned in fluid in their lungs. If you have, an anemic patient that's coding, it's usually because they bled out, those kinds of things. So I would say, although CPR can bring things back, and I've done that successfully. I think the latest data I saw is like 5 to 8% of pets that code for non-anesthetic reasons survive to discharge. In an anesthetic setting, it's closer to 45% survive to discharge, and a lot of that's because there's things that we can do to reverse drugs under anesthesia to bring back our pets and stabilize them. So in terms of, I think the biggest piece of advice of things that you can bring to a general practice is having a plan prior to needing it. So this was something I brought with me to Banfield because I was, like I told you in the beginning, really concerned about being in this situation. My Banfield practice was never practicing ER. They were never practicing code situations. And so when I came there, we got all the Recover stuff. And we set up that every 6 months at one of our team meetings as a team, we practiced running a code. We set up a crash cart where all of our drugs were easily available, and that we had one size of each tube easily available, and it just stayed there all the time, so we weren't looking for it. And then we also made sure that every pet in the hospital had a CPR code. And that is something that's very common in ER practice as well. Any pet that ends up staying in the hospital should have a status of DNR or resuscitate. And that can be hard to talk to clients about because, you're hospitalizing the pet and, getting these things going. And you're like, okay, so if your pet dies, do you want us to try to save it? It's not always something that people are thinking about when they're dropping off, their pet for the spay or, whatever. But I think it's really important to have so that the team has direction. We know what the owner's requests are. And so usually the way I talk about it to clients in a non-emergent setting is usually, we don't expect anything to happen. These procedures are very safe. However, should something happen, what are your wishes? And that is just like a routine thing we ask everybody. Certainly in an ER setting, I think those conversations people are a little bit more understanding and aware of. It doesn't take them out as blue as much because they're coming in because their pet's really sick. And so, having that conversation with them that, if while working this pet up or trying to stabilize, we are unsuccessful and its heart stops, what would you like us to do? But I think being straightforward about it, not being apologetic about it, or trying to use like silly secondary language is kind of important because it's a real thing. There is anesthetic risk out there, and these situations do happen, and clients have a right to be informed about it. So I think as hard as it is to bring it up, I think it's important to do that. And when possible, don't forget to reverse the drugs that you are able to. I have been burned by this before where I didn't realize, or I was jumping in to help with a code on a pet that wasn't mine, and I didn't realize that the pet had been given Domator. And so we started to run code on this animal, and weren't being successful initially, and the vet who had sedated the pet for x-rays came into the back and was like, have you given it antecedent? And we were like, no, nobody here knew that that's what was going on. So I think it's also important that if a pet is being left or has been given drugs or whatnot, that there's a clear way for people to find that in the record, and so that we know what a pet's been given, when it was given, how much was given, so that can be part of what your assistant who's helping with the documentation can look up and tell you from the chart, this is the last things that this pet was given, how much they were given, so that we know if there's opportunities to reverse stuff.
Yeah, and I would say, just jumping in there, any animal that we sedate with dexmedetomidine, we pull up the reversal. So there's
that's my policy too. Mm-hmm.
Available. So I don't think there's any reason why that should be a question. You should just have it on hand, ready to go.
Mm-hmm.
Worst case scenario, you don't use it. So
Mm-hmm.
in our charges in ER for sedation, especially like dexmedetomidine, we have a charge for sedation plus reversal. So even if you have to waste it, oh well, at least right there, and you don't have to second guess.
Yeah, agreed. Okay, so we're going to try to fly through a couple of these. We only have about 10 minutes or so left. I certainly am happy to stay on longer, but want to respect people's time. So, black cats, I think this is probably the most common emergency that you probably will see in practice. Usually it's a cat that has fluted with a stress trigger. Most commonly, that's what I see anyway. And the whole like to cysto or not to cysto question, as a student, I feel like that was something that like some people were like, don't do it, you could rupture the bladder. And other people were like, oh, I do it all the time, it's fine. So in my opinion and in my experience in practice, I cysto. I feel like if the bladder is going to rupture, it probably was going to do it anyway. Just don't squeeze it super hard. So, I mean, if they're that critical, like if they're coming in morbid bound, the most important thing to do is get that cat unblocked, more so than getting a minimum database or anything else. And so a lot for me with block cats, although there's a lot of data you can collect and a lot of data that's super important for long-term management, if they are really, really bad, and basically comatose and obtunded, the only thing that's going to fix that cat at that point is getting it unblocked. So again, trying to multitask as best as you can to get that IV catheter in and a minimum database going, because potassium is certainly important and cardioprotection is certainly important for these cats. Just keeping in mind the only thing that's really going to reverse that hyperkalemia is to get a urinary catheter in and to get that cat flowing. And so often on a true like comatose morbid, like I've had 2 that came in that like didn't have a blink, unresponsive, and those cats we just moved straight forward to unblocking them before we did anything else on those cats, and we didn't actually really need anesthesia on those cats either because they were so bad. I don't usually recommend not using anesthesia because it certainly is super helpful with the spasm of the urethra. But in those 2 cases, those cats basically looked dead, but they still had a weak heartbeat. So, we just went straight forward with unblocking them. I would say my rule of thumb, generally speaking, is that if you listen to the cat and it is tachycardic, and it is acting painful and like rousable, interactive, that cat is likely safe enough for anesthesia to unblock it without having to worry too much about the potassium. With cats that are bradycardic, you're pretty darn sure to get an EKG abnormality on those cats, and they probably have a potassium issue that needs to be thought about to stabilize them or be considered under anesthesia. So this is my little chart in terms of treatment for your potassium. So a mild elevation, I usually just try to relieve the obstruction and correct with fluids. A more moderate one, again, we go to that sodium chloride. And often for these cats, if I don't know their electrolyte status when they arrive, sodium chloride is the first fluid that I will choose, and then I'll switch based off of what blood work looks like later. And then severe ones are the ones that I start thinking about, like, do I need calcium gluconate, sodium bicarb, the glucose insulin combo deal. If you don't have those 2 things available to you, does work and can work well. My preferred anesthesia combo for these kitties is alfaxalone because it's more cardioprotective, but propofol if not available. And then I do put them on gas, and I like to do a caudal tail block. I've found that that's what I've switched to because sometimes it takes you longer than you expect to unblock a cat. And also that the spasm of that urethra is pretty profound in a lot of these cats, and getting that full relaxation you get under gas anesthesia can be super helpful if you're struggling to unblock a cat. I think the caudal tail block helps a lot with that as well, so that I can use less gas anesthesia because they're less painful. But I have certainly seen practitioners unblock cats on like Dextorb and other injectable type sedatives as well. So that's just kind of where I've landed over time in terms of what I found most successful and fastest for me.
We have other questions.
Sure, go for it.
So by caudal tail block, do you mean coccygeal block?
So it's actually not it's actually not like a epidural. So usually you're doing it, so you flex the tail and you find that last, between CD 0 and 1 of the tail. So it's actually in the tail, not in the sacral area. And that will numb basically the perineum area and just that distal aspect of the urethra. So it's not actually a true epidural, which is also why it's a little bit more accessible to do in private practice if you don't have epidural equipment, because you can use like a 18 gauge needle or a 22 gauge needle into that space and put a little lidocaine in there, and you're not contaminating the spinal column at all. So it's a little less scary for a lot of practitioners, and you don't need like special PF morphine or anything like that to put it into the space.
All right, and then I guess tips on doing them successfully.
Sure. So I like my guys, so this one's getting prepared in this picture is getting prepared for the caudal tail block. But I typically like them on their back for me, and I like to tie their legs up or have their legs held forward over the body. I find that that puts them in the best alignment to have more of a straight shot. I find that the other component to, like I said, is getting true relaxation of that urethra. So I like general anesthesia for that reason. It's really hard with like Domator or like just having them on propofol alone to really get that full anesthetic muscular relaxation. And I've actually had a handful of cats where just like getting to that anesthetic plane, they relax enough that you suddenly express out whatever was blocking them. So that's one of the reasons why I'm a big proponent of actually using general anesthesia. In terms of blocking them, I'm a huge fan of the Slippery Sam Mila catheters because they have a stylet in them that makes them more rigid initially, but then you can leave them in place afterwards and remove that stylet, and they can be used long term, so you don't have to try to unblock them with something like a Tomcat catheter and then replace it with like a red rubber or something else that causes more trauma to the urethra. So that would be something, if your practice doesn't have it, might be worth getting a couple of those into the practice to use instead of what they have. I definitely have had cats though that like just because, I would say my piece of advice would be, just because you're frustrated and you feel like it's taking too long to do this does not mean that a clinician that's been out 20 years wouldn't have exactly the same result. There are some cats that are just really difficult to unblock. And I've gone through a Tomcat catheter, a French, a Mila, you're trying all the things. And that happens to everybody. So that's not you not being good enough or you being right out of school. Some cats are just really challenging to unblock, and you kind of have to be persistent and do the retropulsion. Don't get too aggressive, but just stick it out, and eventually they will unblock. I've never had a cat that I wasn't able to unblock, but I've had cats that took me an hour to unblock, so or more. so I would say that it's one of those things that you set yourself up for what you think works the best for you. And for me, that is on their back, legs retracted up over the head, general anesthesia, lots of lube, Mila catheter. But some cats are just more challenging.
Yeah. And then, so we have quite a few questions.
Sure.
Said, I guess the internist at her hospital have said it's really important to correct the hypercalcemia rather than removing the blockage. So giving calcium gluconate to stabilize the heart and insulin dextrose to drive the potassium into cells. I answered a bit quickly and said that, I need to provide more insight. So as far as I've always been concerned in the ER setting, yes, you want to be as cardioprotective as possible. You're monitoring for arrhythmias, and you're, giving your calcium gluconate. You may be starting them on insulin and dextrose. But as far as resolving hyperkalemia, you need to get them unblocked. And you need to get them unblocked as quickly as possible, because for the duration of time that urine's sitting in the bladder, you're never going to be able to get good control of that hyperkalemia. And by just simply de-obstructing them and removing all of that urine, you're going to significantly reduce their potassium levels very quickly. So what are your thoughts on that?
I totally agree with you. I think so. The concern about the hyperkalemia is for anesthetic safety. But I would never wait on unblocking my cat to have full correction first. So I agree that trying to initiate some calcium gluconate, sodium bicarb, whatever it is, as you're unblocking the cat, great. But in private practice, I didn't have those things. And it took me way too much time to do the math for insulin and glucose to make that a realistic thing for me to do prior to trying to unblock that cat. And so I often did not correct potassium at all prior to unblocking my kitty cats. I have been fortunate enough that I have not had one die under anesthesia because of cardio issue. But I think that, again, if you can do it simultaneously, sure. But the other component is that a lot of these things don't last very long. So the calcium gluconate only lasts for about 10 to 15 minutes of cardio protection. And so generally speaking for me, if they're under anesthesia and they're having an arrhythmia, like if we're seeing that happen, that's when I try to institute that in my ER setting. And so I always have them get it out and get it ready, but it's not my top priority.
And then let's see what else. And in regards to that too, I always have a very frank discussion with my owners. And I say, this is a life-threatening emergency and there may be unpredicted complications that may arise and your cat is at risk for sudden death due to cardiac arrest. That's one of those times where I'm pretty blunt and I kind of stress the urgency of this. And I don't beat around the bush in that regard. So I think that's a conversation, just like anesthetic risk, that you need to have with owners, is that your cat could die and we may not be able to change that. And in any regard, we'll try to be as safe as possible, but priority is getting them unblocked. Let's see. So there was questions about drugs used for sedation.
Sure.
Yeah, what your preference is.
Yeah, I mean, like I said, if Alfaxone is available, that's my preferred induction agent, and then I use ISO. If they don't have that, then I use propofol. I have had cats that I've had to unblock under like Domator Hydro and things like that, but it's not my favorite, again, because of the cardiac issues. And they don't get as deep, so you don't get as much relaxation, and it also wears off after about 35 to 40 minutes. So if you have a really tough cat, they could start waking up on you.
Yeah, absolutely. Yeah, and let's see. Someone, Nicole had asked about using sodium bicarb. Would you ever use sodium bicarb? Is it safer to do dextrose insulin first?
So I put these in the order of preference of use for myself. So if they have calcium gluconate, I will use that first. My second favorite option is the sodium bicarb. My personal least favorite option is the glucose insulin combination, because I do find that those cats often become hypoglycemic, and that becomes something else now that I'm trying to manage. I typically, if they have calcium gluconate or sodium bicarb available, I will use those.
Yeah. And then there's a question about using acepromazine as a pre-med. I have never used it. I worry so much about these cats being so clinically dehydrated that they're probably already hypotensive, even though they may look hypertensive because of pain. But
yeah, I usually just give them an opioid for pain, and they're already so out of it most of the time that they don't really need more of a pre-med than that.
Yeah. ACE might just cause even more hypotension after they're unobstructed. So it might just not be worth the risk.
So real quick, we'll just go through and finish up the block cat thing. And then the rest of my slides are kind of like this, where they're written out sentences. So we can post this later for people to go through some of the other ones. But so ideally electrolyte monitoring initially 2 to 4 hours to make sure that your electrolytes are normalizing. And again, addressing that potassium if you need to post-op or post-unblocking. I usually monitor my renal values every 24 hours while they're in hospital, just to see where we're getting, and then check an SDMA in 10 to 14 days to see if there's any long-lasting kidney stress. Again, that's only helpful if the cat is coming in well hydrated. And so if you feel like they aren't well hydrated, sometimes I will give some sub-Q fluids and then draw the blood later. Some of these kitties may have longer term underlying acute kidney injury that goes into chronic renal issues. I always monitor my ins and outs on these cats because they have post-obstructive diuresis. They're dehydrated. They've not been eating. They've been vomiting. So usually initially I'm on aggressive fluid rate of closer to 3 times maintenance if they have a healthy heart. And then I back it off over time, based off of how those kidney values are doing. But you want to be making sure that you're keeping up with how much they're diuresing out as well. So that's something to watch. And then the urinary catheter should stay in place for ideally a minimum of 72 hours. I have some clinicians that I've met that take it out at 48. I just get a little nervous because you caused a lot of trauma and inflammation in the urethra by placing the catheter in the first place. And so that needs some time to heal as well. And then going home and in hospital, once they're taking things PO, I usually send them with prazosin, buprenorphine, antibiotics. It's a bit controversial because they often don't have a UTI, but sometimes your catheter replacement wasn't as sterile as you'd like it to be. So if I'm concerned about contamination, I'll do that. I do Serenia for appetite stimulation and to treat uremic nausea. And then diet for life for sure. A lot of the behaviorists are considering and recommending also starting these kiddos on fluoxetine because so many of them are actually like behavioral fluted cats, especially if there wasn't like a obvious, infection or something like that that came back on culture. I'm not a huge fan of Onsior in these kitties because I worry about their kidneys, but I definitely have some friends that like to use Onsior because they assume like the kidneys are otherwise healthy except for this event. And once they're on fluids and they're being diuresed and everything else, like there's a lot of great kidney support happening. It's just not my favorite thing because I don't know, NSAIDs and bad kidneys just don't go together in my brain. So I typically stick with buprenorphine for my pain control. But so I also have stuff on like polytrauma, the ATE thing. I'll just throw this out there real quick, but the classic saddle thrombus doesn't happen as often as you might think, and throwing an arterial thrombosis can happen anywhere in the, anywhere in a cat's body. So sometimes these do present more as like weird amorphous lamenesses, acute abdominal pain if they went to the gut, acute kidney failure if it went to a kidney. I've had respiratory distress because they have pulmonary thromboembolism. So just remembering that this could and can and should be a differential for any cat that you're working up that you can't really figure out what's going wrong. And for a lot of those cats, if you have a fast scan, it's worth checking the heart real quick on a cat coming in, kind of ADR weird acute change situation, just to see, do you notice signs of HCM? Do you notice things like clot formation and stuff in the heart that might make you more suspicious for it? So anyways, we're out of time. We're like 10 minutes over. It's been a great conversation. I certainly can do more of this in the future if you guys all find that beneficial and Dr. Marshall has time on a schedule on a day that we can go through more. But hopefully this has been helpful for everyone. And my biggest takeaway I would hope that all of you would have is you've got this. There's only 3 things that you have to memorize. Everything else you can look up in a book. And if nothing else, give them a little bit of Torb, put them in an oxygen cage, and take a deep breath yourself.
And sedated. Not put them in a car if they can't breathe.
Yeah. Mm-hmm.
Can I stop? Everybody's saying thank you.
It's really, really good. Don't worry about going over. People will get off if they need to, but
Sure.
We're still recording, so so we'll have it for people. But that's great.
Yeah. Well, thank you.
You bet. So 1:45 back on this channel on at least Pacific time if you want to hear much more truncated, lots of little things in one lecture as opposed to stuff in depth like this on the things that you need to know about cats, but you probably won't learn in vet school. And that'll be probably go from Pacific time probably till 3. So a little bit longer than an hour, especially how people, as far as people having questions, and hopefully it'll be geared to be more interactive in person. We'll see how it goes in a Zoom type setting, but we'll figure it out.
And that's about an hour and a half from now, right? For people that are doing math for different time zones.
Yes, exactly an hour and a half from now. So
okay.
Yeah, so go get some lunch or go get some dinner. Bring a cocktail if you're on the East Coast, and you can join us, and we'll have a happy hour.
All right. Well, thank you, Paula, for your help today.
Melanie.
Oh, all right. Anna's already started. I love it.
For contact information, just in case people have questions following up.
Oh, sure. Yeah, I have. Hold on. Let me get to the last slide. Yeah. So, like I said, I love. Oops. connecting with people, mentoring students. If you want, I can email you this PowerPoint as well that has the information. So my email is melpidvm@gmail.com. You can find me on Instagram at vacationvet. And then I actually also have a website, drmelaniebowden.com, that has my information there as well. So.
Okay, thanks, Melanie.
Yeah.
Yeah, and Paula at Beyond the White Coat on Instagram.
Yep.
Okay, thanks you guys.
Perfect.
I'm going to shut down this meeting and get ready for the next one in an hour and a half.
All right.
Thanks.
Have a good
Thanks.
day.
You bet. Thanks, Mel. Thanks, Paula.